All right, so this is a review of Goyal-Post Stroke. So make sure glucose is okay. If it's too high, give insulin. If it's low, give him glucose. Blood pressure, if it's too high, decrease it slowly, 15% in 24 hours. Temperature, make sure it's, they're not freezing. All right, so dysphagia, why is that even important? Patient can't swallow, big deal. It leads to aspiration, which is a cause of pneumonia. Give them a nulla per os or nil per os status, so nobody feeds them anything. Put them on the side so they don't swallow their spit. Kind of like your friends in college, angina, myocardial infarction, ischemia. The chance of these complications is 1 CHD equivalent. Venous thrombosis and pulmonary embolism. Some of the risk factors are age, severity of stroke, immobilization, and atrial fibrillation. Give them low molecular weight heparin, aspirin, or IPC. It's just not as good. IPC is counterindicated if the patient has been bedridden for a while, or if they have some ischemic-like problem. Heparin prevents DVT and PE, and there's a 7 and 38. Also, she later mentions sort of DVT and PE associated with cord injuries, and there she says calf compressors and warfarin are also viable. Alright, so then you have skin problems, mainly bed sores. You move the patient around. If there is a bed sore, then you make sure it's clean. Musculoskeletal problems, mainly fractures. Why do they get fractures? Because they fall, because they can't walk. And that's it. A GI problem, bleeding, which is pretty common and pretty bad. Give prophylaxis and PPI, especially if the patient is in ICU. GU problems, UTI, you can have incontinence, which is common, 30 to 80% of stroke patients. Detressor hyperreflexia, you treat it with scheduled voiding, fluid restrictions, and anticholinergics. You could have a sexual problem, which for males you can't ejaculate. For females, you just don't like sex. Psych problems, patients are depressed. In neuro problems, patients have seizures, usually happen in acute cases of stroke, and they happen a few days afterwards or a few months afterwards. Do not treat with prophylaxis for seizures, that's not recommended. Alright, so send the patient to rehab for functional improvement, for increased range of motion, to keep him mobilized. Mobilize them in the first or second day unless they have a counterindication like coma, hemorrhage, obtundation, orthostatic hypotension, those things. Alright, so you keep the patient in the hospital if they depend on you functionally, and that includes ADL and mobility. You send them home. Otherwise, what level of aid you send along with them. If the patient can only do up to 25% of their total activities, complete total aid full-time. Between 25 to 49% to 50%, then you give a maximal aid, but not complete. Up to 75%, then you give a moderate aid. Up to 99%, they still need something, then you give a minimal. And if it's 100%, except they need some sort of direction, inspiration, give them supervision. So they call you up on the phone and you're like, yeah, open that toothpaste, open it up, go ahead. Alright, so what things to consider when you're deciding on where to send them to rehab, family, support group? People, are they disabled cognitively? Can they understand endurance? Because some of these rehab centers require you to sort of keep up. If you could do 3 hours of physical therapy, intense rehabilitation center. If the patient has some sort of a complicated medical disease, then that intense rehabilitation is provided for them in a hospital setting where there's physicians and yada yada. Alright, so what do you expect from rehab? You expect some sort of a physical therapy, exercise, improve function. If the function doesn't improve, you could do a compensatory technique, sign language if they can't talk. Teach them how to use adaptive devices for whatever disability they have. Alright, a couple more things to consider. Aphasia. 40% of stroke patients have it, and most improve, but if they don't give them some sort of a speech therapy, and if that doesn't work, compensatory techniques. Driving, 50% can't drive, visual spatial problems, distracted, too slow, report that to the DMV and you just kind of let them deal with it. Prevent another stroke, decrease risk, hypertension, diabetes, smoking, cholesterol, 2 of these factors, then it's way worse. You could also do a pharmaceutical treatment by antiplatelets. Aspirin is pretty common and useful. If that doesn't work, ticlopidogrel or ticlopidin, one of those. Then you do, let's say patient has atrial fibrillation, you give them some sort of an anticoagulant, clipping of aneurysm, bury aneurysm if they have it, and also carotid and arthrectomy. All right, so recovering cord injury has to happen within 6 months or otherwise it's not going to get better. Loose thermoregulation, make sure it's not from an infection. Incontinence for distressor, you give them anticholinergics like oxybutynin. For sphincter problems, you give them terazose and alpha blocker. Bladder reflexia, you put a catheter, bowel disimpacted, make sure it's not distended. DVT and pulmonary embolism, calf compressors, heparin, warfarin. Prophylaxis for decubitus ulcers and spasticity, you treat it with stretches, baclofen, tizanidine, diazepam, and if they need adaptive devices, you provide.